Hello everyone, I'm Ashton Green. I am a rising third-year dental student, and I've sort of changed the title of my project from what's on the paper, so as you all know, research is ever evolving. So currently, I'm looking into improving dental care compliance in individuals living with HIV. So, a little background. What is HIV? For those that do not know, HIV stands for Human Immunodeficiency Virus. It's a virus that's spread through bodily fluids. This virus attacks your body's CD4 or T cells, weakening your body's immune system and making you more susceptible to opportunistic infections. Untreated HIV can progress to AIDS, which is acquired immunodeficiency syndrome. So who has HIV? Oh goodness. Sorry, this is a little new. Okay, so in 2014, the CDC estimated that currently 1.1 million people in the United States are living with HIV, and 1 in 7 do not know of it. From 2008 to 2014, the estimated number of annual HIV infections was luckily on the decline by 18%. From previous years, and the current population who is most impacted is gay and bisexual men. Sorry everyone, I'm having a little trouble with this. Okay, HIV and race. So, as you see in this chart here, African American, specifically men who have sex with men, are the most highly impacted individuals that are diagnosed with this disease, and it's definitely higher than other races and ethnicities. In 2015, African Americans accounted for 45% of annual HIV diagnoses, which is very alarming because African Americans only make up 12% of the country's population. HIV and income. As you see in this particular chart, income has a huge determinant on who may or may not be infected with this disease. The prevalence is highest in urban and low income or poverty-stricken areas, as you see on the far left. The prevalence is inversely related to household income, and it improves significantly with higher income, obviously. So there is definitely a correlation between poverty and race. This chart shows that poverty, though, may account for the greatest disparity versus just looking at race alone. But as we know that race and poverty are definitely correlated. African Americans tend to be, sorry, lost my train of thought. So racial disparities are less apparent when different racial groups are equally impoverished. So if you have a mixed group of racial identities and they're all equally impoverished, their odds of having this infection are more equal than, anyway, poverty is the main determinant. Sorry, I'm rambling, I'm a little nervous. So how has HIV impacted citizens in Louisville? This is a map of Louisville and the smaller sub-neighborhoods. I'm not from Louisville, so I'm not as familiar with these areas, but this is downtown, this little sliver here, and the surrounding areas. And this here is a map of age-related HIV death rates. The darker colors here correlate to higher deaths due to HIV, and you see that downtown that I showed before, this sliver here, is, oh, you can't see my pointer, the darker concentration. That happens to be where downtown and West Louisville is, and they're greatly downtown and West Louisville and the surrounding areas to where we're currently at are heavily impacted by HIV, and people are dying at higher numbers than the surrounding area. So some of the HIV programs in Louisville are, as you see here, there's the Kentuckiana AIDS Alliance, there's Volunteers of America, there's the 550 Clinic across the street actually, and there's also the Kentucky Cabinet for Health and Family Services, specifically the Kentucky HIV and AIDS Care Coordinator Program. And I added this fact too, as of June 30th, 2016, there were 9,000, almost 10,000 cumulative HIV diagnoses reported to the Cabinet for Health and Family Services Department in Louisville. So when I was thinking about my project, I've always been interested in HIV, and I wanted to know where I could potentially help. I'm a dental student, so I wanted to take a oral health approach to this disease and how to assist. So after having many conversations with very knowledgeable people, I came to the conclusion that dental compliance is definitely lacking in this population of people. Of course, that could be due to various reasons, like access to care, it could be transportation, it could be childcare, various different things versus people just not understand, or it could be also that people just don't understand the importance of managing their disease. I wanted to look at is this actually due to their lack of understanding of why it's important to have dental care with this diagnosis, and that is the basis for my project. So why is dental care important for patients with HIV? So oral signs are often the first indication that there is a systemic problem. The oral cavity in general mirrors your overall health in your body. If you have a sick mouth, then there's probably something else going on inside, because your mouth is where everything pretty much enters your body. Looking at HIV patients in general, about 30 to 80% do have oral manifestations, so it's definitely important to look at their dental care and if they're keeping up with their dental care. And another thing to consider too is that when you have HIV, you could have some oral manifestations that could inhibit your normal functions. Even simply eating could be compromised, and for people who need to be on a very strict medication regime, if you're unable to eat, then you're probably not going to take your medications, and that could spiral out of control. So my plan as of now is divided up into 3 phases. The first phase is to look at the community's perspective of HIV-related oral manifestations. I want to know what people know about HIV and how it relates to their mouth. And then with that information, I want to create some sort of educational module with the community's input where we could collaborate and figure out a way to address this together. And then phase 3 is the testing of whether or not this educational module is effective. And all of this is in an effort to improve dental compliance again. So phase 1, more specifically, community perspective of HIV-related oral manifestations. I plan to look at or come up with focus groups and also conduct individual interviews to determine. I wanted to determine what individuals know about their diagnosis and how that affects their dental care. I plan to have open discussions with individuals and also come up with questionnaires with people who are very, with experts, with dental experts and also caseworkers. In the community of interest, as of now, are patients who are enrolled in the Kentucky Care Coordinator Program, and I chose that program because I know a few individuals who work very closely with it, and are very familiar with it. Phase 2 would be to create an educational module with the people within my focus group. This education module will be formed, like I said, in collaboration with these individuals with the goal to improve their compliance. Not their specific, but patients in general compliance. The information from phase 1 is going to help determine the trajectory of phase 2. And I don't know exactly at this moment what feedback I will get, but I'm open to letting the community determine what is important to them, what they do know and what they don't know. I don't want to go in assuming that these are their problems, this is what you need to know, because maybe they do know certain things. And anyway, that's the point of being collaborative. So I also learned a bit about the health belief model. It's a theory where individuals with better information make better health decisions, especially when they believe they're susceptible to certain conditions. That's something to definitely consider with this population of people, because sometimes people just don't know how their, I guess, HIV status impacts them. And with this educational module, perhaps they'll have a better understanding about the seriousness of their condition and how to better address it. Because providing information alone is not enough. From my understanding now, the care coordinator program is required to tell these patients specific things, but I feel that perhaps emphasis could be lacking, and that's what I'm hoping to create with these patients. So community collaboration will keep the educational content relevant to their needs and understanding, and I think that would make it more valuable long term. So an example of what I thought could be a potentially good educational module would be something as simple as like a trifold brochure that I make with the information with the focus groups. This brochure basically would contain images of how HIV affects the oral cavity. We often say that a picture is worth 1,000 words. Sometimes a visual can help really emphasize the importance or the gravity of what not managing your disease can do to you. It'll also reinforce the importance of dental and oral health, and it can also contain facts and statistics that people deem important. And some of the examples could be images like these. These are images I'm very familiar with in my field, but the average person who is not very aware of oral health and how it relates to their HIV diagnosis might be very impacted by this. These are very graphic, and perhaps they could be used to further motivate people to continue getting the dental care that they need. So phase 3 is the testing the impact of the educational module. I plan to do that with some sort of pre-test and post-test, and that would contain questions I would come up with some experts, some either the care coordinators that I'll be working with, or some of my mentors. My vision moving forward would be to also incorporate this educational module in the current Kentucky Care Coordinator dental package. Like I said, there are dental coordinators that coordinate the plans for these patients and making sure they get the dental care that they need, but perhaps the educational part is a bit lacking, and if we could incorporate this with their within the information they're already required to give these patients, perhaps we can further emphasize, like I said, the importance of dental and oral health and why they need to proceed with their dental care. If the patients better understand their condition and the risks associated with it, they might be more likely to maintain appropriate treatment recommendations, i.e. compliance. So to track compliance, this is a little tricky. I know that most patients that are currently receiving care from the Care Coordinator Program go to the 550 clinic, or they're referred to the Elizabethtown Clinic. I have yet to learn about which other clinics these patients are sent to specifically, but ideally, compliance could be potentially measured by observing attendance changes, if there are any, within these different dental clinics that these patients are sent to. And I would look at that I would measure that by looking at the unduplicated numbers of HIV patients that are referred and recommended from the Care Coordinator Program. And I wanted to say thank you to Dr. Sherry Babbage, Dr. Ryan Combs, Dr. Faye Jones, Dr. Ken Krieger, Dr. Katie Leslie, and Deborah Wade. Without all of you, I wouldn't have stumbled through this presentation. So thank you all for bearing with me. I get really nervous, but that's my project, so thank you. Another disclaimer, I am very new to the world of research, so all of your comments and critiques are welcomed. Yes.
A fellow newbie speaking to another newbie. It seems to me like you've got almost a whole lifelong career worth of research wrapped up in one project. That being said, I get a little ambitious too. I think even just starting with understanding what the perceptions were, that qualitative work that you were looking at up front is almost its own project.
Right.
And if there is a gap in the literature about what we know with oral health care compliance in that population, which I don't know much about, here on a local level, if you're looking at the local level, just trying to understand what's going on there, I think that would be a great point to start. And then you're talking about creating an intervention, and that's a whole group of work, and then you want to do your pre-test, post-test. So, and kind of building off of Dr. Polifka's recommendation earlier, there might already be instruments out there that allow you to test some of that, so you don't have to read them at the wheel as a word. But I think it's really interesting. I like where your head is going, but it seems like you're thinking long term. So it'll be exciting to see what you came up with. But that's just sort of my thoughts on the newbie to the newbie. So, I think you did great with your presentation. Technical issues aside, you did great. So.
Thanks.
I just want to offer a comment, because I know that when you got to some of the later parts where you're talking about education, and you mentioned some earlier barriers. I know that we've had this conversation about if you're doing focus groups or individual interviews with patients in the Care Coordinator Program, you were also going to examine some of those other barriers, not just the knowledge piece as well.
Because I know it's not that simple.
I just wanted to further emphasize that.
Yeah, for sure.
And just a stigma with the disease could be one of the barriers.
Right. Yes.
I too think that you did great. It's a huge project. So even thinking about how would you scale it to make it, multiple phases for multiple projects in the future. One of the things that is just kudos to you, for this health equity report, this will be the first time that we are actually focusing on oral health data to really show the importance of oral health to other diseases. And so we do need this type of study to kind of show some of the comorbidities, in a sense, that people have, and how we can be just at the root cause of some of these events when we focus on perhaps two co-occurring things, such as oral health as an issue as well as HIV that you're showing. So we would just really love to have your data published so we can write it up in our head.